have a powerhouse panel for this next segment, which I'm very excited about. We have also agreed amongst the four of us that I will not try to pronounce everybody's name. So instead, we have Dr. N, Dr. O, and Dr. M. And you can see them pictured on the screen.
Dr. G.
Very lovely headshots. So today, I think we want to get into aging as it relates to health equity. By 2040, the 65 and older population will have doubled since 2000. In 40 short years, we'll have double the 65 and older population because medications are keeping people alive longer. Healthcare in the US is arguably superior in allowing people to age in place and have access to healthcare that is life-sustaining. So we want to hear from our panel uniquely kind of on how they see health equity as being central to the conversation going forward. So I have actually an individual question for each of you, as opposed to like a jump ball where we all kind of react to it. So Dr. Olewala, we'll start with you. You're responsible for setting the health equity agenda at Humana, which is which is the epicenter of Medicare Advantage, arguably in the United States. That's no small job at all. As we see the 65 and older population diversifying with each passing year, what do you believe we should all be thinking about in keeping the conversation alive and thinking about how to refine our approach to serving a more diverse marketplace of members?
Yeah. Well, first of all, good morning, everybody. It's such a pleasure to be here, and thank you for having this. And I'm really honored to be beside my other panelists. So I have the good fortune of serving as Humana's first Chief Health Equity Officer and Senior Vice President, which was a role that was created not too long after the killing of Breonna Taylor, which happened just a few blocks down the road from where Humana's headquarters are in Louisville, Kentucky. And it was the moment where a lot of folks were thinking, like, what is our responsibility in justice and in all its forms, education, social, criminal, health, and so. But Humana had already done a lot of really great work for years prior to my role being created in the space of looking at our members' social needs, understanding the needs of populations at large, and zooming out to understand what populations needed, and then kind of zooming back in to create really good equitable experiences for them. But really wanted to widen the aperture around our look at equity. So. And then kind of a parallel current that was happening at the same time, as you all probably know, is that in Medicare Advantage, which, as you said, we're the epicenter of Medicare Advantage. I love that. I actually have not heard anybody say that, so I'm going to take that back to Humana. As Medicare Advantage continues to grow, we're seeing increasingly it's becoming the Medicare of choice for African American and Hispanic consumers increasingly. So as that's happening and our work around this is happening, it's important for us to think through, well, what does it look like as our demographics shift, as we have a majority-minority flip by 2040, people are living longer, they're living well. Well, aging means very different things to different populations. And we have to really think through, how do you make sure that people, if they're aging in place, how do they do it with dignity, but how do you do it in a way that's culturally competent? We're providing care that reflects and acknowledges the importance of culture in people's lives and how they make decisions and who helps them make decisions. So we know with a lot of our conversations with our members and our patients who are racial and ethnic minorities, the importance of family and the caregivers and the people around them as they make decisions is hugely important. But we also know that one of the fastest growing aging populations are those that live alone. So how do you kind of reconcile the need to really embrace the spirit of family, culture that is important for aging, but also this other phenomenon of people being alone? So we're thinking about all those kind of things every day. And I will just say that if you hear me say nothing else during the course of this morning, just remember this one: you will never get health equity by accident. Like, you can't just do good things and it will happen. You have to be like really intentionally looking at your member populations, your patient populations, disaggregating, understanding their unique experiences, and then really being thoughtful in how you design programs around them.
Incredible. And as a follow-up to that, we here at PAPA that housing is one of the most difficult social drivers of health to solve for. How do you care for a member and think about their health when they might be evicted in a month or might not be able to pay for their rent?
Yeah, it's well, I have seen that happen firsthand. I had a patient I took care of many years ago. I'm a family doctor, and I was managing his care for weeks and weeks and titrating his insulin up, and up and up and up and up, and faxing increasing doses of his insulin to the faxing. You heard me say that, so that tells you how far back I was. Faxing that over to the pharmacy, and then one of the we call them access to care workers in my community health center came to me and said, "Dr. O, do you know that he is homeless?" And so the next time I saw him, I asked him, and I said, "Oh, you never told me." He said, "Oh, well, you never asked." And what was happening is he couldn't get access or didn't have anywhere to put the insulin, was living in his car and was never filling those doses. So it's impossible to care for people that are without considering the stability of their housing and their living, and whatever that housing might be. So we've made a lot of investments in housing just because we feel like if you can do all you want with really great benefits and a really great strong provider network, but if people are not kind of safely and appropriately housed, you can't do much. So Humana's made a lot of investments in housing in lots of our key markets over the last few years.
Incredible. Dr. Nair, if you would also introduce yourself and then perhaps address the confluence of data and technology as a rheumatologist in serving populations that are more difficult to reach and economically challenged.
You got it. So first of all, Chuck, thank you so much to the Papa team, Andrew, Emily, everyone for inviting me here. You got the initial wrong, Chuck. It's Dr. G, but we're going to let it go.
2 out of 3.
Like Dr. O, I went into medicine. I became a rheumatologist because I think old people rock. I think it's a problem with our culture, right? I think old people vote also, right? So they are an important constituency in our culture. And in the South Asian culture, which I belong to, we really revere the elderly. And it's a big part of my passion and why I went into rheumatology in the first place. As a doctor of tech, what I would say is that we need to give more credit to the aging population. My parents are some of the smartest people in the world. I wouldn't tell them that, but I do actually regard them. And we've made technology too hard. We blame the end user. Oh, it's those old people. Oh, it's those doctors. They just don't know how to use their EHR. We have to make technology that is intuitive to everyone, including the elderly. You should not need a training manual. You should not need someone sitting next to you to show you how to use the tech. The tech should work just like, and I'm not promoting Apple, but when you take out an Apple product, you just start using it, right? So we need to start thinking about the aging population and the technology we use to serve them as being better and rising to the end user rather than blaming the end user. And we have to be doing exactly what you guys are doing at Papa, which is doing it in the home, giving our elderly the dignity of being in their home. Everybody wants to be in their home. Nobody aspires to be in a hospital or a nursing home or assisted living. So we have to start extending that and being really smart about the fact that we have a workforce shortage. We're not going to have doctors in the home. We're not going to have a lot of nurses in the home. So how do we use, very similar to your concept, Papa did not ask me to say this, but I am truly enamored by their vision. How do you use some sort of aid in the home to then extend what can be done medically, right? Whether it's your diabetic diet, whether it's transportation, whether it's loneliness, which we heard about earlier, these are all social determinants of health, which are that much more important in aging. And I actually think easier to solve if we recognize that and start building the tech to serve the problem as opposed to just building the tech and then creating 6 new problems. So I know that was a lot. I'm gonna be quiet now.
Well, that was excellent. No, that was excellent. As a redirect, why does ageism exist, and how can we get rid of ageism?
Oh gosh, I think so much of that is cultural, to be honest with you. I wish I had the answer to that. Again, coming from the South Asian culture, we really revere the elderly. I think the American culture is very different. I think we also have to realize people are living longer and are more productive longer. And so whether it's working from home, whether it's thinking through mentoring programs of those with a lot of wisdom, being paired with younger folks who are new to an industry, we can make our elderly workforce a lot more productive. We've just chosen not to. I think historically, domestically, right? Yeah. 65 is sort of that epicenter, since you're the epicenter of Medicare Advantage, right? 65 is really young. people are very productive in their 70s, their 80s, and we sort of just have this magical number we came up with. I certainly don't plan to be retired when I'm 65. I know she's not, right?
Yeah, I'm not.
We're going to be doing all kinds of stuff, and we're going to be doing it probably remotely and all around the world, and that's how we have to start thinking of our elderly has so much experience. We have discounted them way too early, and we're all living older. So I think we do. I think it's a cultural issue more than anything.
I concur. We talked a little bit about it yesterday. 11,000 people will have a birthday today. They will turn 65, and tomorrow, 11,000 more. And Saturday, 11,000 more. That's a lot of people aging into Medicare. And these are people who are vibrant. They're running marathons. They're active. Dr. Medrano, you are a nationally recognized psychiatrist, and you have a particular emphasis in the use of psychedelics in treating behavioral health challenges. Speak to us about how that can become more mainstream in addressing some of the topics we've tackled in the last 48 hours.
Thanks, Chuck. Actually, I want to thank Papa for hazarding inviting me here, as I'm probably going to be one of the more oddballs of the group. As you mentioned there, I work in the psychedelic sector, which is a growing area of healthcare right now. And just a little bit about how I got into that. So I think a part of my mission in talking about this is to begin to be part of the normalization of the exploration of consciousness for well-being. Because this is actually where things are going, whether we like it or not. Because at this point, Johns Hopkins, many other major respected research institutions have validated the use of psilocybin, psychedelic mushrooms, MDMA, as many people know that MDMA is sort of on its track to FDA approval, probably by next year. So that's formerly known as the party drug ecstasy, if you're not aware. And you'll see many more psychedelics over the next decade being legalized for clinical use and gradually being decriminalized state by state, as we're already starting to see. And so for me, how did I get into this? So I was just sharing here with some of our panelists, back in my teens, I got to explore a lot with psychedelics. And I think a lot of people do, and they just don't talk about it. And for me personally, it was very helpful because it helped me bring meaning into a lot of challenging things that were going on in my life. And so through that, it pretty much led me to becoming a psychiatrist. I was an aspiring Buddhist monk at one point, and then I realized actually I'd be more useful if I was actually not in a cave, as I was asking one of the panelists at one of the earlier talks. So I went into psychiatry actually with a lot of passion for how do we make meaning of all the challenges that we have, including aging. It is unavoidable. Old age, sickness, and death, these are the Buddhist tenets, the principal Buddhist tenets. We're all subject to this. And so how do we actually navigate that? And so as we see this paradigm shift in mental health with psychedelics, we're beginning to see this paradigm shift as not just psychedelics, but integrative psychiatry as a whole, looking at mindfulness, yoga. All of these things are becoming very broadly accepted. So as we sort of turn back to the topics that we're talking about here, how do we bridge the barriers that come with treatments like psychedelics? So my work at Field Trip, we found that it's actually quite expensive to cover this multidisciplinary team to come to this beautiful setting. And so I began to work with another company to use telehealth interventions called New Life. And I see the potential for a wonderful marriage with some services like Papa, where we could have people there in the home to sort of help them safely navigate these tools.
Dr. Medrano, I took care of my father when he was in diapers. He took care of me when I was in diapers. So the circle of life, as you suggested, is inevitable. Tell the audience one thing that you're excited about, that a current innovation or a future innovation that can allow seniors to age in a more dignified way going forward.
Yeah, well, I mean, this is part of it. So as we're looking at how do we make meaning of our later years, like these tools pretty much show us, for most people, when they're guided properly in the proper set and setting with the proper trained provider, can allow people to begin to find that for themselves. So, you know, moving into their older age with a sense of grace and a sense of knowing what it is that they have to offer to others. Again, I think it does require connection, not just a great therapist, but a sense of connection with that therapist. So it does actually, it demands a little bit more for the mental health care providers to really also feel a passion for what they're doing. The beauty of what I see evolving in this work is that a lot of people who get into this are actually people who have experienced it themselves. So they've begun to become settled with the challenging things in their lives so that they could be more present. One thing that I'm really excited about, and I'm starting to see this in studies that are happening, is sort of community-based interventions with psychedelics. So having a group of people of similar demographics actually doing journey work with, we call it journey work, with ketamine. And actually in Canada, because of a compassionate care initiative, they're allowed to use psilocybin as well. And so I know some researchers there that are actually doing this group work, and it's creating a deeper sense of community as they listen to people sharing together. And we start to address some of the things that we may have lost as we were talking earlier about, you know, essentially moving from a collectivist society to an individualist society, where we sort of lost touch with the importance of our heritage, our ancestry, and all of those bridges or mountains or oceans that our ancestors have crossed, that we could begin to sort of see the value in honoring that and honoring our place in relation to our community more, rather than trying to sort of, you know, pit ourselves out as, or stand out, so to speak, and say that, oh, I've got this by myself, you know. As valuable as that is, I think when you start doing community work, you see more of your interconnectedness, so to speak, and yeah.
Thank you. Dr. G, what excites you? What are you seeing out there that you're kind of keeping your eye on and monitoring the trend lines in terms of innovation for the aging populations?
Sure. So I'm encouraged, you know, one, that we continue to talk about mental health, which I think is a huge issue globally in healthcare, definitely in the aging population. But I'm also encouraged by this push into community, and we really saw this with COVID, right? The retailization of health, the idea that you can go into your local drugstore, your local pharmacy, and yes, you won't get a doctor or a nurse most likely, but that relationship with the pharmacist, the next time you go to a retailer or your local grocery store, I encourage you to see how much time everyone there spends with the pharmacist. For those with chronic diseases, many 65 and older, there's always a question to be asked. There's always some tip to be given, and it's always the pharmacist that's doing that. And I think it's great to see that we are extending care, that we are pushing it into the community locally in a way that really got catapulted because of COVID. And I think that's part of the journey into the home, that's part of the journey into the innovations in that space. But I think we do need to continue to lean into those that are physically in our community, have stakeholders that actually know the local community, and that you don't need to wait in a waiting room, right? Having your pharmacist there, I think, is just an add-on or a complement to that patient-physician relationship, and I'm encouraged by it.
Incredible. Dr. O, I have an interesting question for you. Medicare Part C offers such a rich and broad array of services and benefits to a member. How do we get enrollment higher? It seems like I came from educated parents and they never understood Medicare Advantage or anything that was going on other than at a very rudimentary level. Are we as an industry communicating properly, do we think, on the benefits of Medicare Advantage, and why can't we get more people to access these services?
Yeah, I was looking at, so I have two wonderful and very brilliant parents like Dr. G does, and having the opportunity to see them going through the reviewing what they get and trying to select plans has been illuminating for me. I would argue that many of us that work in plans and kind of are in places where we should understand Medicare probably don't understand it as well as we think we do. And as you certainly feel like you don't understand it once you are trying to enroll in something and make a decision on a plan, and all these agents are calling them, and they're just, it's a lot. So I think that we communicate in language that is not real people language, and we're not recognizing kind of so many nuances that are in the way we describe things. People have varying levels of basic adult literacy, varying levels of health literacy, and varying levels of health insurance literacy. And so we write things as if people work in those companies and should therefore understand. And so I think we have to really think about how we communicate. But I also think that we don't, and I'm not speaking for Medicare Advantage specifically, but we just don't kind of sell the value of what you have. And I think when you're an aging person, I've seen it particularly with my parents, like, you know, you feel like people are like trying to get over on you all the time. And so it doesn't matter what it is. If it's milk, you know, it's like, I don't know, is that real? You know, is that a real cow? Or they just feel like, oh, people are always trying to, you know, do something. Right. So how do I make sure that this is real? So I also think that's part of the challenge, is that it's not something. Then you've got, you know, commercials like in the middle of the day all the time that are saying all sorts of things. And it's very hard to actually break it down. So one of the things that we are doing, and in fact, one of my colleagues, should be here, Emily, from my team, has done a lot of work prior to, oh, there she is right there. Hi, Emily. Has done a lot of work prior to even being on my team in kind of communication of benefits in simple, clear language that people can understand, that people can use to make decisions, bringing in visuals and other sorts of cues that help people understand what they're doing. And so I think that's a really important way to do it. And then I would argue, and again, this is not because I'm here at this meeting, but I think that there's also the Papa Pals that are the folks that are kind of in the home, helping people when they're alone, trying to make decisions, equipping folks like that are making these connections, that are building trust with people in their environments, is another way to, I think, help them kind of get through some of these challenges and understanding.
Yeah, no, I think we look at the senior population a lot, and I hear all the time, oh, seniors use cell phones more than you think. I'm not so sure. I think there are some, you know, every passing year. I have a brother who's 64, he'll be in Medicare Advantage next year, and he is a technologist at General Motors, so he knows how to use a cell phone. But people who are 80 right now, I remember my mom, I got her an iPhone, and half the time it wasn't charged, and when we did charge it, she forgot her password. It was just like, I give up. And so, Dr. O, what's one thing that Humana's doing that's exciting you right now? Obviously nothing confidential, but, you know, at the forefront of healthcare, what is Humana doing to enable more technology in some of the seniors' homes?
Well, first I'm going to argue with the fact that, with your comment about, you know, aging folks not using cell phones as much. I will say with my senior family members, when we finish this panel, if I put on my phone, I probably have 50 forwards from my parents and my aunts and uncles, like group texts and all kinds of happy March and all sorts of things are going to be in there. I think I think there are a lot of folks that really do, and I'm originally from Nigeria, and even when I was just there a few months ago, and even Nigeria, like our aging folks actively consume technology in ways that I think actually would surprise a lot of folks. So I think we just, to Dr. G's point earlier, we have to make it easier for them to do it. If we make it too complicated, they're not going to do it. But it is a really good, smart technology is a really good way to reach and influence, I think, aging folks. So I do think we should, I just want to, say that before I respond. But but it's not necessarily for everyone. You have to be thoughtful and, what do you want people to use? I love going to like an Apple store and you see the Genius Bar area. And I was there in one a few weeks ago and I saw lots of elderly seniors in the area. Right. And they were going through all sorts of things, trying to learn how to use different things. And so being really designing things with empathy and thinking of your end user and not just designing things so that you can design them, but thinking like, well, if I do this, and this segment of the population is growing, and they're here to stay, and they're aging, and they have needs that they're going to be able to. We need to help satisfy. If we're thinking about that as we're building the technology, then I think we will not miss them. But if we're just building things and we think, well, they're just going to work across all generations, and everybody should be able to use them and consume them the same, then I think we'll have challenges. So I think it's just a lot more intentional. So we're doing a lot of work in the digital space. Lots of places where your touches at Humana will be not only digitized, but like really true digital experiences from the moment you're enrolling to when you're onboarding to when you're interacting with our pharmacy teams to when you're getting your pharmacy, your medications by mail order, and you can use the app to kind of track your work. There are lots of different ways that we're doing it. And then we're also integrating a lot of work around understanding our members and patients' social needs, and using a lot of digital IVR, different sorts of tools to understand those things, and then kind of reinforcing like the responses to those kinds of social needs at the point of care. So Nicole from my team is doing a lot of work in like integrating those sorts of screening things into the places where patients and members are getting interactions with our team. So I think there are a lot of opportunities, and I think we should not say they won't use it, so let's not try to develop. I think we should think they will use it, they increasingly are using it. How do we make sure that we do it in a thoughtful way?
Exactly. I appreciate that perspective. We've also, at PAPA, been discussing with some of the large telecom companies that are focusing on 50 and older, like telecommunication products, like phone, tablet, like a whole suite of services. So it's kind of interesting to see those companies start to have that level of concentration. Incredible panel. Let's get some questions going and open it up to the audience. What would you like to know from this powerhouse trio? Brendan Keeney, what's your question?
I guess, Dr. Medrano, I'm curious, psychedelics, like what excites you in the research and like what opportunities have the ability to create? I'd love to hear more on that. There's so many things this conference we found out new, and this one just hit me, like the Parkinson's comments yesterday about, some of the role that we play from an environmental perspective. So curious if you'd comment more.
Yeah, I mean, there's so many, but I guess I'll pick one of the most relevant ones, which is really what's coming next. So for MDMA, as I had mentioned before, it is currently in phase 3. It's pretty close to the end of phase 3 of the FDA approval process, and I think it's there's no doubt it's on track for approval, most likely next year. And what is it approved for? For PTSD. And so I'm sure there's going to be a lot of off-label indications that'll follow thereafter, but what's so promising about it for PTSD is the fact that we're actually seeing these massive effect size for this, and that is just unseen anywhere else in mental health care. For example, the participants in this study, well, in the many studies leading up to it, they've actually been doing studies now for a few years. They've been able to do long-term follow-up studies, and it's somewhere around 66% of these people who had severe PTSD. So these are like classically diagnosed, a lot of them veterans, who no longer qualify for PTSD, which is mind-blowing. And to just think that after 3 sessions with MDMA with these trained therapists, that 6 months to a year out, that they no longer have these symptoms. They've gotten their lives back. And to see that, I mean, the only thing that I could think of that was sort of equivalent to it in the past was when we sort of saw how electroconvulsive therapy, ECT, was able to sort of get people back to normal and not have too many side effects outside of the memory issues that happen around the treatment. But there's not really a lot of other treatments that we've seen in psychiatry that really equate to that level of effect. And we're seeing that amongst all the psychedelics, like that we're seeing right now with all the research with psilocybin for end-of-life anxiety. That's probably one of the most relevant topics to this population that we're talking about here. How do people actually deal with, either end-of-life or patients who have actually received cancer treatment and are trying to recover from the depression or anxiety that actually occurs there. We've seen a good amount of research from, again, respected institutions, NYU for the psilocybin end-of-life study, and Hopkins as well. So these are, strong well-crafted studies, I think, are pretty reliable. You know, we're past the point of them being sort of early findings, and now we're just sort of moving these medicines out there. And one last thing, in regards to ketamine, it's interesting because it's an orphan drug. It's been around for a while. We've been using it since the 70s as an anesthetic primarily. But in the last 15 years or so, ketamine has had, volumes of research around its use for treatment-resistant depression. And having similar findings as we talked about with PTSD, albeit that the response is more of a short-term response. I think that's because a lot of the ketamine research has not been paired with the sort of psychedelic therapies that MDMA has. But I think we're going to find when you start to pair ketamine, one that is a very, it promotes a great deal of neuroplasticity, and that's well known. So if you start to pair it with things like health coaching and not just the psychedelic therapy itself, that you can start to see lasting behavioral change. And that's what we're starting to see in the field, but we need more research to really validate that.
Thank you. Thank you all for a great discussion. Dr. Madrano, this question is for you. So the question's been raised that how come some folks respond better to loneliness or anxiety or any challenges of life compared to others? Now, in Hindu and Buddhist culture, you know, we believe that we're not just product of our current life experiences, but perhaps many more. Dr. Brian Weiss, who's out of Miami, I'm sure you know who I'm talking about, had done a lot of work on regression therapy. So, any role of that in dealing with mental health challenges that you see?
I love that question. Thank you. I think the first thing that just sort of dawned on me is how unconventional a question like that might seem to us right now, and how I actually feel like probably within 10 to 20 years, it'll be probably a little bit more normalized when we think about part of what you're getting at is intergenerational, potentially some intergenerational aspect, but you're also referring to previous lives, reincarnation. Now, again, I think I keep using the word meaning, or the term meaning making. I think for us to ever really validate that there's previous lives is probably beyond our science at this time. But for us to be able to find in these experiences and working with these molecules that there might be something in our sort of unconscious that holds a lot of meaning to why we're struggling now. And so that is really valuable, whether it's true or not. And for many people who have these experiences to say, I now understand this is something I've been struggling with for lifetimes. And when they come away and they say, that was the most meaningful experience in my entire life. It's a rarely common thing you hear with psychedelics. It's top 3, they'll usually say top 3 most meaningful experience. And these are people that they follow up with like into their 70s and 80s who may have been part of those studies back in the 50s and 60s with LSD. And they're still saying the same thing, and it's still been that transformative for them. Now there's, on the other side, I was getting into genetics or intergenerational trauma. I think we're gonna see a lot of momentum in this over the next decade because there are actual respected researchers like Rachel Yehuda out of Mount Sinai Hospital. She does specific work on epigenetics in relation to traumatized populations like Holocaust survivors and then their progeny. And she has been able to see that there are actual genetic markers of trauma in these populations. And we're starting to see some very early research I think he wrote The Fellowship of the River, Dr. Tafur, and I think Rachel Yehuda even has an interest in this, that psychedelics can begin to maybe reverse some of these changes on this DNA. And so essentially seeing a biomarker of how we might be able to work with intergenerational trauma in a positive way.
Thank you all for being on the panel today. It's been a fantastic discussion. Dr. O, I'm curious from an equity perspective. I think you mentioned yourself that you had a patient that you didn't know was homeless because that person never said anything. And so how do we in the industry and in health plans, and maybe others on the panel want to answer as well, understand better our populations, beyond just their healthcare status or what we've, seen within an EMR. For example, Eric, the CEO of Oregon Health Plan yesterday, said that they were giving people air conditionings. Well, the problem with that wasn't necessarily the air conditioning, but they had no electricity. And so how do you really understand from a social equity perspective what's happening across various populations?
Yeah, it's a really good question. And I will just say, Andrew, that was much earlier in my career, and I learned a lot from that. And I think that was what started to make me think, oh, well, there's probably so much that we don't know because we are not asking. And, people don't just offer up things like that if there's not a reason to do so. So, one thing is, it seems so like trite to say this, but like screening people for those needs that they have that may not be medical. So, you all know you go to a doctor's office and we ask you lots of questions about your family history and your, if you drink and if you smoke and if you have any medical problems, you've taken medications. We have a whole kind of formula that we all know that we kind of go through that we do almost consistently every time. And usually, and when I was in medical school, and probably the same for my colleagues, when we got to the social history, it was, how much tobacco do you use, how much alcohol do you use, and do you use any drugs, illicit or not? And then, maybe who do you live with at home? Sometimes pediatrics or guns in the home. But for the most part, it was a pretty standard set. And pushing further into actual social needs is still a relatively newer phenomenon in healthcare, to integrate that into that part of the set. And I remember back about 2013, I was giving this talk. I was talking about, at this big kind of conference of a bunch of physicians and talking about the importance of really asking about social needs. And I got slammed. On the stage, they were like, we're doing too much in medicine. We're asking medicine to do too much. Medicine isn't social work. We can't do all these things. And it was really, there was a lot of resistance to doing that at that time. So I think now we're much more understanding the fact that we can't give really good care. I could never have cared for that man well if I didn't address the housing issue, which was really the issue. And I have zillions of stories like that, and so do most people. So we bringing that into, normalizing that in the healthcare space, and not thinking, okay, well, if they go to a social service agency, they'll find out those things and they'll deal with those things. We have to bring that actually into healthcare and continue to bring it. So screening people for a range of social needs, and we're obviously doing that for transportation. It's a huge challenge for aging populations. How will I get to, the grocery store or to the bank if I'm living alone, or to my appointments? Housing and not just, are you housed? Are you safely housed? Right? Is important. And then food, consistency of food, and having security around your food and knowing that you're going to be able to have meals. And then also, many other social needs, but like loneliness and social isolation, how you're doing. So these are things that we actually can build into the healthcare environment, whether it's on the plan side, where we're learning about our members as we're bringing them on, or as we're interacting with them at different points in their journey with us. The health system side, when you're kind of enrolling, bringing in new patients, there are a lot of places to do that. I would just say that at the same time, when you're doing that, and one of the things why I think there was so much resistance in the physician community about doing this is that, well, if we do it, we need to be able to have the services to support them. And I was the principal investigator on a research study years back at University of California, San Francisco, and San Francisco General, where we looked at 500 physicians across the San Francisco Bay Area and what some of the biggest factors were that were influencing their burnout. And what we found was that the number one thing that influenced the burnout of our primary care clinicians, this was VA settings, safety net hospital settings, and also like faculty practice settings, was understanding your patient's social needs and not having resources to do anything about it. So it wasn't about kind of understanding them in the screening part of it was actually not having something to do about it. So if you're going to do that and make the clinical and plan communities more willing to do it, you've got to be able to couple that with the resource to do something about it if you find something. And so that also requires a different set of muscles, and you've got to community, like understanding what resources are in your communities, deepening your knowledge of communities, and some of my community engagement folks are here, Lisa, Tam, and making sure that you know those things, you know who are the resources in the communities, how do you tap into them, and how do you get people into things that they might need when you screen them positive. So I think that it's that. it's building in the screening, but also building in the resources around them, knowing who's in your environment, and what, and some of that is like just individual encounters, but we also have like, resources that are electronic that you can use to find those things. I hope that answered your question. Okay. What's that? Well, Papa's always a good idea to solve everything. That's kind of understood. I just, thank you.
What else?
I have questions and comments, and probably too many, so I'll try to keep it short. But so the first part is for Dr. Medrano. So I have the luxury, frankly, of working in a large hospice organization where I can prescribe ketamine pretty easily. And it's been really amazing for some of my patients with limited life expectancy where we need a more rapid response for depression. But I'm curious, what you see going into the future in terms of, are these going to be therapies really reserved to be prescribed only by psychiatry, or do you see them moving into the primary care space, given so many people are really treated in primary care? So that's question number one. Question number two for the entire panel with a comment is that when my father died and my mom was left alone and far from where my sister and I lived, we tried to automate everything for her. Get your prescriptions delivered, let me deliver groceries. And then I went with my mom around town and I saw she knows the person at the deli counter at Whole Foods because my dad ate prosciutto every day and would convince him to give him the best pieces. Her pharmacist actually knows her at CVS, which is not my experience at the CVS in San Francisco. And she didn't want any of that delivery because that was actually part of her community and forming connection. And so while there's positives about reducing barriers to getting these things, we're actually making people more isolated. And so just wondering how you think about it from a large, health plan perspective and also at Salesforce. So that was a lot, so sorry.
You're very smart. You got all your questions in at once. I'm going to do that next time. I love it. Yeah, very efficient.
I'll reserve answering the second half to the rest of the panel. So so regarding hospice and ketamine, and I'm happy to hear that you're actually using it already. That's wonderful. I mean, I'm hearing that more and more. It is a hot topic in the ketamine-assisted therapy community. There's actually a big multi-site study coming out, I think led by Phil Wolfson and the Ketamine Research Foundation, to actually look at that specific intervention. So I think in more palliative, but ultimately that will lead to hospice, of course. So I'm trying to think of the first part of your question. Oh, primary care. So yes, actually, in the company that I'm with, Chief Medical Officer of New Life, which is a tech-based company that's trying to bring ketamine into home-based treatment. So we offer health coaching, integration specialists. So integration is the kind of therapy that you do around psychedelics. And we ship ketamine lozenges to people's home and team them up with that team as well as a prescriber. Part of our model, we have our direct-to-consumer model where we have our own prescribers. A lot of them are actually not psychiatric prescribers. They're FNPs or advanced practicing nurses. But another part of the model is beginning to actually bring that whole system of care and marrying it with advances in technology so that we can allow other prescribers, like primary care providers, to feel comfortable instead of them feeling like, oh, I don't know what to do when I write this script. Like, I don't know how much to write. I don't know anything about the therapy. I don't have a collaborative team that I work with. Just eliminating all those barriers and say, hey, in partnership with us, we'll work with you on this. And we'll have a co-manager to sort of help advise you on dosing, on what to, we'll do the screening for you even, and so that you can feel more comfortable about the safety profile of this. And so I do see that as one intervention towards or solution to how to actually bring this to primary care. It is actually our intention to bring this to primary care providers. I mean, we know in mental health that they're actually the ones prescribing the most antidepressants. And so in reality, the shortage of mental health care, of psychiatrists, psych nurse practitioners, it's just going to keep growing or shrinking, I guess, to be Exactly. And so this is how we're going to have to do this. Otherwise, there's going to be a massive barrier to access if we don't. And so I think the future is that, yeah.
Sure. So I'm happy, and I won't pretend to have the answer to your question, your three-part question that I think is brilliant. I think the conundrum you mentioned with your family is very similar to the story of technology. In solving one problem, you created two other downstream problems you didn't see, right? So I think it actually goes back to what Dr. O mentioned, which is really it's all well-intentioned, right? It's like, Mom, what are the things that we can help you with? Like, maybe it's half the groceries, maybe it's a certain type of grocery, maybe it's the heavy groceries, right? But maybe it's not the whole thing, because that's her social time. And alternatively, with the new technologies that are out there, are there ways that technology can give her a more additive social experience that's less lonely? Whether it's talking to grandkids, whether it's someone to come and take her for a walk, whether it's her, again, we discount our elderly sometimes. The elderly are so good mentoring kids, right? College kids, younger kids. I mean, there's kind of these two spectrums of loneliness when you're young and when you're old. And pairing those together can sometimes, Papa's doing this, right? There's a beauty in that, and there's a natural respect and regard that happens. And so finding those opportunities, I think, are important, or volunteering, but it's a tough question. I think it's why we're all sitting here, but really analyzing your mom, understanding your family's situation, what gives her joy and what gives her pain, and then what you can solve for and automate, and what you maybe shouldn't automate and leave it to her. It's a tough question.
It's interesting, the Scandinavian countries specifically are very well known for solving for like the college housing issue by pairing up
That's right.
people, young college students living with older people who help them, but also learn from them. And it just accomplishes a number of things. I think I agree with that 100%. I know that having my kids exposed to my parents, like the stories and the things that they remember and the lessons that they learned, like I couldn't have taught them that, but they would listen to the wiser older people. So I think that can be magical in many ways. I think we have time for one more question for this powerhouse panel. Brandon Hamilton, what was your question again, sir?
Sure. I'm going to repeat the question because I'm not sure everyone heard it. So the question was, in the employer space, where do we see sort of benefits going and evolving? I think we've seen it very dynamically, right? It was work from anywhere, no, work from the office, Monday, Wednesday, Friday, psych, Monday through Friday, get back in 9 to 5. And now everyone's depressed and anxious and losing their jobs, right? So I think we continue to unfortunately live in a dynamic world and environment. I think this year is going to be tough, right, economically, which will impact every industry, not just healthcare and all the different ways that can affect patient populations. In the employer space, I think it's very important to keep a pulse of your employees, right? Every company is different. You have a young population, an old population, a middle-aged population, a mix, a remote workforce, an in-person workforce. So number one, knowing your employees and what are the issues unique to them. Mental health, he knows this best, right? Mental health benefits, doubling down on those, whether it's telemedicine, whether it's prescription benefits, therapies, just a support system all around for coaching, mentoring. I think that will continue to be important for many, many years, not just this year. And also, I think culture, right? There's this piece around culture that kind of waxed and waned during COVID because so many folks were remote, and now you're seeing this drawback to coming to the office. Keeping in mind on resetting your culture, if it wasn't right before, perhaps there's an opportunity to reset it and get it right now, right? And to constantly seek that feedback. I think it's important in the benefit space not to get stale. And there are really cool benefits out there. There are innovative companies like Papa. There are amazing companies to partner with like a Humana. So I think wanting to understand and be really open to the innovations happening in the space and thinking really differently. thinking really differently about benefits and understanding what drives people, right? Is it the parking? Is it the remote schedule? You know, is it childcare? Is it having access to a gym or being able to, you know, get reimbursed for a gym membership? Everyone is motivated differently, but I think to the extent employers continue to understand that, they'll have a more productive, happier workforce and community for us to all be in.
And I agree with that 100%, and I think that employers are possibly more savvy now on the subject of
Definitely.
caregiver support than they were pre-pandemic. I know we got a lot of phone calls from some very large employers saying, hey, we want to offer you in kind of a caregiver support package, annual subscription to Netflix, gym membership prepaid, Uber Eats, Papa, other things. You don't have to be sick. You don't have to have a life event to use. You can actually use them day one. Exciting stuff.
And I'll add one more comment, sorry, I'll add one more comment. Healthcare is expensive, so the employer benefits piece, it's very important, not just because it's the right thing to do, but healthcare is very expensive. And if you do it correctly, you will save a lot of money as an employer, right? The mammogram is way better than breast cancer, the colonoscopy better than colon cancer. The active person before they're depressed or anxious or overburdened as a caregiver is going to make them more productive at workforce. So prevention remains key, but it will directly affect the bottom line and employee productivity, and that's why it remains that much more important in this economy.
I just want to add one thing to what Dr. G said, because I thought about it as she was speaking. Also, I think that what you're commenting about culture is so important, that if you had a bad, toxic culture when you were all in the office, and you think that you'll improve that when you're kind of remote and in these hybrid working conditions, it'll never happen. But I do want to just say that it's really also important as employers to think through, like, what are the needs of the different demographics of folks that you have in the office. So you hear a lot about African American workers having reluctance to come back to the office because they experienced a lot of microaggressions, and they felt much safer, psychologically safer in the remote environment than they do, and just really understanding what are the unique needs of your different employees, and not just, they're not a monolith, and you can cut and slice and dice that by so many different parts of their demographic composition, but really being thoughtful about what do people need based on who they are and the kind of all the intersections that they carry, and then also living the culture as leaders. So it's one thing to say, like, we've got this benefit for childcare, but anytime you say you have to take your child somewhere, your leaders, your boss is like, weren't you just out with your kid last week? So right, you've got to be able to, like, make sure that you're living and allowing for that space, even if you even if you have something that's kind of written in black and white as a benefit.
That's so true. Things are so different now as we start to go back out into the world and things reset to kind of the new normal. I know that my sales team and I travel. We go to empty buildings.
Yeah.
Like health plans that used to have 4,000 people. There's a security guard, and then there's our contact.
One day,
Dr. You need to meet the employees where they are,
Yep.
because they're not in the office anymore. And so there's a whole new set of dynamics that we're going to probably be studying for years to come. Thank you.
I'm gonna add one more comment to that, and I promise I'll stop. But we have been living, and chronically we've been living in this era of misinformation and disinformation in healthcare, but it obviously got heightened during the pandemic, and the stakes couldn't have been higher. So I think as a cultural piece and as an employer responsible for the health of X amount of the population, it's really important, I think, to come out strong on just knowledge about health, right? Not making the decision for an employee, but it should be cool. It should be important to know about your health. It should be important to understand why you should get the flu shot, why you should go to your doctor annually, why you should have a doctor, frankly, right? So I think these things, because of the pandemic, got heightened, and it's really important as you're building your culture to remember that. Just being healthy was so top of mind and part of every culture during COVID. I wouldn't lose that piece. I would lean into it. Right, and whether it's a series, whether it's webinars, whether it's just your benefits, team coming out, making you smart on what's available to you, you can never go wrong when you side on facts in healthcare.
Incredible. One last question.
One last question. So throughout this discussion, obviously, it's very clear the widespread issue of loneliness and the impact of it. And Dr. Medrano, you did mention something about group journey and the effectiveness of that in clinical settings. What's your thoughts about incorporating those findings into not clinical settings or even services like PAPA and really creating that sense of maybe community that it's very clear that could be very effective and reduces the impact of loneliness?
Yeah, it's a good question. There's like two parts to it too, right? Because part of what we're talking about is, part of what you're mentioning is non-clinical. So I think about betterment to the well, the topic of betterment to the well, right? Where, and this is really like preventative mental health, basically. Like, and it's a topic that's starting to grow. Actually, at Hopkins, they are starting to look into this more with psychedelics. Like, they're studying, healthy normals, basically, and looking to see, how does that in the long term benefit them. So I think there is some future to that. The other part is about connection. So, I think probably it's not lost on any of us here that part of why we're even here, why PAPA exists, is because we're in a crisis of disconnection, really. That more and more we're feeling disconnected. And so getting to your point in the question, why I feel it's promising to do these sort of group experiences is exactly that. There's one thing to, have somebody give you a call, ask how you're doing, and obviously that's helpful. There's another thing to actually sit across the room from someone and hear that they're sharing similar struggles as you, and that they know that you hear them. And at the end of that, you know that they heard you and what it was that you're struggling with. And as simple as that sounds, to know that those guards that we usually have up most of the time are dropped, and that we can actually feel that sense of true empathy from a group as a whole. I don't think that I've come across anything quite as profoundly healing as that. And I think we're going to see that more and more in that research. And that's part of the excitement of this, because that's not just like, how do we deal with people with existential related anxiety or depression, but for any of us, really. Any of us could benefit from that, to be able to know that we're not alone. And yeah, so I don't think I have anything to add.
I think a big round of applause.